Welcome back to the Deep Dive, the place where we turn massive textbooks into immediate clinical wisdom.
Uh-huh.
If you are a nursing student gearing up for a med-surg rotation, or maybe you're a practicing clinician who just needs a sharp evidence-based review, well, today is for you. We're focusing on one of the most foundational and, let's be honest, complex systems in the human body.
The gastrointestinal tract.
The GI tract.
That's right. Our subject today is a complete synthesis of GI assessment, and we're pulling exclusively from Chapter 38 of Brunner and Sudworth's Medical Surgical Nursing text.
The gold standard.
Exactly. We're talking about mastering the entire pathway that runs from mouth to anus, a potential battlefield that spans almost 8 meters.
And our mission today is very targeted. We are going to distill every single core concept, every assessment technique, every, nuanced pathophysiologic mechanism, and really, most importantly,
Every crucial nursing implication.
yes, every high-stakes nursing implication required to assess GI function. The goal is for you to walk onto the clinical floor feeling truly well-informed.
And the central clinical focus here is really comprehensive assessment. I mean, the GI tract is susceptible to major organic diseases. We're talking about things like significant bleeding, obstruction, inflammation, cancer.
The big stuff.
The big stuff. But as nurses, we also have to recognize and assess those powerful extrinsic factors that so often disrupt this system. Stress, fatigue, anxiety, and of course, diet. A holistic assessment is it's non-negotiable.
Okay, let's unpack this enormous topic.
Yeah.
And I think we have to start with the essential vocabulary. If you're building your foundation, these terms are just key. We have 4 core phases for how we process a meal. First up, we have ingestion.
Yeah, this is the simple mechanical phase. It's just taking food and drink into the GI tract, via the mouth and esophagus.
Then the real work begins with digestion.
Right. This is the breakdown phase. So through the action of mechanical churning and chemical enzymes and secretions, all those large molecules, your proteins, your fats, complex sugars, they're systematically broken down into smaller, absorbable components.
Next is the main event, absorption.
And this is where the body extracts everything it needs. The small molecules created during digestion, along with essential vitamins and minerals, pass through the specialized walls of the small and large intestines and then get distributed into the bloodstream.
And finally, what the body doesn't need, elimination.
This is just the evacuation of the resulting waste products from the body. It's the conclusion of that whole process.
Okay, we also need to define 2 really crucial terms we'll be using throughout this deep dive. First, the substance that's actually moving through the system, chyme.
Right, so chyme is that specific, thick, kind of semi-liquid mixture. It's the food you swallowed combined with saliva, enzymes, and those highly acidic gastric secretions. That's what it becomes once it hits the stomach.
And the most common clinical complaint you are going to hear in relation to this system, dyspepsia.
Dyspepsia. It's the technical formal term for indigestion. Clinically, you define it as discomfort that's localized to the upper abdomen, and it's often associated with or even aggravated by eating. Understanding its character is just paramount during that history-taking phase.
Now that we have the glossary down, let's travel that immense pathway. We're starting with the tube that gets the food down to the mixer, the esophagus.
Okay, so the esophagus is about 25 centimeters long. It's a muscular tube that transports the food bolus. Anatomically, it sits in the mediastinum, right behind the trachea and the heart. For nurses, the key structure to know is where it passes through the diaphragm.
That's the diaphragmatic hiatus.
That's the one.
And its function is primarily just mechanical transport. Right?
Yes, mostly. It happens through peristalsis, these rhythmic waves of muscular contraction. And then at the bottom, we have the lower esophageal sphincter, or LES. This muscular ring has to relax to let food into the stomach, and then, crucially, it has to close tightly right afterward to prevent reflux of all that acidic gastric content.
So decreased LES pressure is a major factor in heartburn.
A huge factor.
Okay, that brings us to the stomach. Can you walk us through its architecture?
Sure. The stomach is located in the left upper abdomen, and it's remarkably distensible. It can hold up to 1,500 millious.
1.5 liters.
Yep. Its major functions are to receive and store food, mix it all up with those powerful digestive fluids, and then propel the resulting chyme into the small intestine.
What are the key anatomical checkpoints that control its function?
Well, you have 4 main regions. The cardia is where the esophagus enters. Then there's the dome-shaped fundus and the main area, the body. The outlet is the pylorus, which leads to the duodenum. And that exit is guarded by the pyloric sphincter, which is a powerful ring of smooth muscle.
And the pyloric sphincter acts as a gatekeeper, doesn't it?
Absolutely. It makes sure that large food particles can't pass through. They have to be churned and reduced until they are small enough. It's a process that's vital for efficient digestion in the small intestine. That sphincter only opens reflexively to let small amounts of chyme pass when the duodenum signals it's ready.
Let's talk about the stomach's secretions. You said they are powerful, maybe even a little terrifying, given how acidic they are?
They are powerful, no question. The stomach produces up to 2.4 liters of fluid a day, and the pH can plunge as low as 1.
1. That's incredibly acidic.
It is. The secretion process has two major roles: chemically breaking down food and acting as a sterilization agent. It destroys the vast majority of ingested bacteria.
So what are the three essential chemical players secreted by the stomach lining?
Okay, first, the heavy hitter, hydrochloric acid, or HCl. That provides the extreme acidity needed to break down things like connective tissue and cell walls. Second is pepsin, which is derived from pepsinogen and is the enzyme that really kicks off protein digestion.
And the third player is one that's often forgotten, but clinically it's so critical.
That is intrinsic factor. This is an absolute must-know for nurses. Intrinsic factor is required because it has to combine with dietary vitamin B12 for that vitamin to be absorbed way down the line in the ileum.
So if your patient has atrophy or damage to the gastric mucosa, maybe from chronic gastritis or a surgery, and their intrinsic factor production drops.
They cannot absorb B12. Simple as that. This leads directly to a deficiency state, which presents clinically as pernicious anemia.
That's a huge clinical link.
It is. The clinical teaching point here is that a hematologic condition, anemia, is actually caused by a primary failure in the GI tract's secretory function. You have to internalize that connection.
Okay, so once the stomach has done its thing, acidified and churned the chyme, it moves into what you call the absorption powerhouse, the small intestine.
This is where most of the magic really happens. It's the longest segment, taking up 2/3 of the GI tract's length. But because of its special structure, it's covered in folds and these tiny, finger-like projections called villi. It provides an immense surface area for secretion and absorption.
How much surface area are we talking?
About 70 square meters, that's like 230 feet worth.
Wow. And we have 3 segments here.
Right. We travel from the proximal section, the duodenum, which is short and C-shaped, to the middle section, the jejunum, and then the distal section, the ileum. The ileum ends at the ileocecal valve.
And that's like a checkpoint.
Exactly. It's a one-way checkpoint that controls the flow into the large intestine. And, really importantly, it prevents the reflux of bacteria back up into the small intestine, where absorption has to stay clean.
And the small intestine doesn't work alone, does it? It relies heavily on the accessory organs.
Correct. The common bile duct, which delivers bile from the liver and gallbladder and powerful digestive juices from the pancreas, empties right into the duodenum at a place called the ampulla of Vater.
Let's discuss what those pancreatic and biliary secretions actually do.
Okay, so they achieve two crucial things: neutralization and emulsification. Pancreatic secretions are highly alkaline. They're rich in bicarbonate.
And why is that so critical?
Because it neutralizes the high acidity of the chyme coming from the stomach. I mean, if that chyme stayed that acidic, it would rapidly damage the duodenum.
Okay, so that's neutralization. What about the breakdown crew of pancreatic enzymes?
So the pancreas delivers the core chemical breakdown crew. You've got trypsin, the protein cutter, amylase, the starch dissolver, and lipase, the fat splitter. Then separately, the liver secretes bile, which is stored and concentrated in the gallbladder. Bile is basically the GI tract's natural detergent.
A detergent. How does that work?
Well, bile acids aid in emulsifying fats. They take these large globs of ingested fat and break them into much smaller droplets. This increases the surface area dramatically, so the lipase enzyme can effectively cut them down and get them ready for absorption.
And that flow is tightly regulated.
Very tightly regulated by the sphincter of Oddi, right where the duct enters the duodenum.
So that whole process involves mechanical mixing and chemical breakdown.
Oh.
Let's look at GI motility in the small intestine.
So there are two major types of movement here. First, you have segmentation contractions. These are stationary, localized churning and mixing waves. They just move the contents back and forth over a short distance.
And that's for absorption.
Exactly. It maximizes the contact between the chyme and the intestinal walls. Then second, you have intestinal peristalsis, which are the wave-like movements that propel the material slowly forward toward the colon.
And what are the final building blocks that get absorbed?
The finished products are carbohydrates reduced to monosaccharides, like glucose, our body's main fuel. Proteins become amino acids and peptides, and fats become monoglycerides and fatty acids. The chyme stays in the small intestine for about 3 to 6 hours while all this happens.
Is specific absorption sites are another key concept here, right?
Yes, absorption is very geographically specific. The jejunum is the real workhorse. It absorbs most of the fats, proteins, carbohydrates, sodium, and chloride. But there are two crucial substances reserved for the distal segment:
Which are?
vitamin B12 and bile salts. They are absorbed almost exclusively in the ileum. And this is really important when you're assessing patients who have had small bowel resection surgery.
So how is this incredibly complex sequence system, all the churning, the neutralizing, the propelling, how is it all managed and regulated?
It's governed by a pretty sophisticated internal regulatory system, sometimes called the enteric nervous system. It involves neuroregulators and hormonal feedback loops. If we look at the nervous system, the sympathetic nerves usually provide an inhibitory function. They decrease secretions and motility.
And the parasympathetic, the rest and digest system.
That provides the stimulation. Parasympathetic input increases peristalsis and secretory activities. Acetylcholine is the key neurotransmitter here, often acting as the accelerator, and it's stimulated by the sheer distension of the stomach. On the other hand, norepinephrine is generally inhibitory.
Okay, now for the hormonal police that manage the flow of chyme. Let's synthesize the three main hormones that are outlined in the text from table 38-2.
Right. These three hormones work as a tightly coordinated system. They're especially important for policing that acidic chyme as it enters the duodenum.
Okay, starting with gastrin.
Gastrin is stimulated by vagal input and, interestingly, by calcium-containing foods. Its main job is to crank up the production of hydrochloric acid in the stomach, preparing that environment for digestion.
Then we have cholecystokinin, or CCK.
CCK is the fat response hormone. It's released when protein digestion products and, crucially, long-chain fatty acids hit the duodenum. It has a couple of roles. It triggers the gallbladder to release bile and the pancreas to release its enzyme-rich secretions.
But its most important regulatory function
Is that it slows gastric emptying. If the chyme is really fatty, CCK basically tells the stomach to hold off, which gives the duodenum enough time to process the fat and prevent an overload.
And finally, secretin.
Secretin is the acidity alarm. It's released when the pH of the chyme in the duodenum drops too low, so below 3. Secretin's action is to inhibit gastrin and gastric acid secretion and generally just decrease GI motility. It's like an emergency brake, making sure the alkaline pancreatic secretions have time to neutralize the acid before more gets dumped in.
The coordination is just remarkable. Okay, let's conclude this section with the last leg of the journey, colonic function and elimination. What's the major job of the large intestine?
The large intestine's role really shifts from nutrient absorption to resource recovery. Its main function is the efficient reabsorption of water and electrolytes. The muscular contractions, the peristalsis, are much slower and weaker here compared to the small intestine.
And how long does the waste stay there?
Well, that slowness is what allows for the efficient water reabsorption. While waste usually reaches the rectum about 12 hours after a meal, it can be deceptively slow. The text actually notes that as much as 25% of the waste from a single meal might still be in the rectum up to 3 days after you ate it.
Wow. And what are the final waste products, the feces? What are they actually composed of?
Stool is about 75% fluid and 25% solid material. That includes things like undigested cellulose, inorganic substances, and a very high concentration of bacteria. The brown color comes from the breakdown of bilirubin and bile, and that characteristic odor comes from volatile gases like methane, hydrogen sulfide, and ammonia, which are all produced by bacterial action.
Okay, and the final mechanism is the defecation reflex. What is the nursing takeaway regarding control here?
The reflex starts when the rectum distends. This initiates contractions and relaxes the internal anal sphincter, which is under autonomic control, so it's involuntary.
But the external sphincter is different.
Exactly. And this is the key clinical teaching point. The external anal sphincter is under conscious control via the cerebral cortex. Defecation is a spinal reflex that we can voluntarily inhibit or initiate, which is fundamental to successful bowel training programs.
You touch upon the high concentration of bacteria in the large intestine. This leads us to one of the most dynamic and, well, current areas of GI research. The gut microbiome.
Yes, and this is an absolutely critical concept for modern medical surgical nursing. The gut microbiota, that's the collective community of microorganisms in the GI tract, it's not just passive, it's an active player in your health. Its functions go way beyond just assisting in waste breakdown. It's vital for specific vitamin synthesis, like vitamin K, and most importantly, for immune function.
So how does this living ecosystem contribute to our immune defense?
The collective genome of this community, the microbiome, acts as a living, dynamic shield. It produces anti-inflammatory metabolites, it breaks down toxins, it physically prevents pathogenic species from colonizing, and it helps regulate our immune responses.
And the intestinal lining itself has specialized defenses, doesn't it?
It does. The intestinal epithelium acts as the first line of defense, housing crucial immune cells like macrophages and T cells. We also find specialized lymph tissue in the ileum known as Peyer's patches, which are a huge part of the gut-associated lymphoid tissue, or GALT, and they aid in that immune defense.
And when is this complex internal ecosystem established?
Colonization begins immediately after birth, and the normal gut microbiota is usually established within the first 2 years of life. But its composition stays fluid throughout your life, and it's intensely influenced by genetics, your diet, hygiene, infections, and certain medications.
And this leads us directly to the clinical reality of antibiotic use.
Right. Broad-spectrum antibiotics are maybe the biggest non-disease disruptor of the microbiome. They just wipe out the healthy competitive flora, creating a vacuum that allows opportunistic pathogens to flourish.
And that's how we get C. diff.
That is the direct mechanism by which patients slip hospital-acquired infections like Clostridium difficile or C. diff. It really highlights the need for vigilance and appropriate prophylaxis.
Let's shift our focus to the effects of time. Table 38-3 systematically outlines the gerontologic considerations, how the GI tract changes with age. What's the central idea here?
The main takeaway is that while the GI tract has this vast functional reserve, meaning aging alone rarely causes severe dysfunction, the structural and motility changes that do happen significantly increase the prevalence and severity of common disorders.
Okay, walk us through the major anatomical segments, starting with the oral cavity.
As we age, we often see loss of teeth, atrophy of the taste buds, and, critically for digestion, decreased production of saliva, TLN, and amylase. The clinical implication for the patient is pretty significant: difficulty chewing and swallowing, which can lead to poor nutritional intake and a higher choking risk.
Down to the esophagus.
We see decreased motility and slower emptying, combined with a weakened gag reflex. And, crucially, there's decreased resting pressure in the lower esophageal sphincter. So what does this mean for your older adult patient?
More reflex.
A much higher prevalence of reflux and heartburn symptoms.
And the stomach's function declines as well.
Yes, the mucosal surfaces undergo atrophy, which results in decreased production of HCl and digestive enzymes. Gastric motility and emptying also slow down. The consequences are things like food intolerances, issues with malabsorption, and, tying back to our earlier point, a severe risk of decreased vitamin B12 absorption due to lower intrinsic factor secretion.
Which increases the risk for pernicious anemia.
Exactly.
In the small intestine, the absorption powerhouse becomes a little less effective.
A little less, yeah. The villi, those specialized absorption projections, they thin out. We see atrophy of the muscle and mucosal surfaces. This thinning directly reduces the efficiency of absorption for vital nutrients like dextrose, fats, calcium, and iron.
And the final segment, the large intestine.
Here we encounter reduced mucus secretion and, importantly, decreased elasticity of the rectal wall. We also see decreased tone in the internal anal sphincter, combined with duller nerve impulses in the rectal area. These shifts result in slower motility, which increases the risk of chronic constipation, and sadly, they are major contributing factors to fecal incontinence in older adults.
So as nurses, we have to assess for these age-related factors proactively.
You have to.
The health history is the absolute starting point for GI assessment. We rely so heavily on the patient to articulate their symptoms. What are the key symptoms we have to systematically elicit?
We have to cover abdominal pain, dyspepsia, gas, nausea and vomiting, diarrhea, constipation, jaundice, any changes in appetite, and a history of previous GI disease.
Let's focus on pain, which is so often the presenting complaint. Beyond just asking, where does it hurt? What specific characteristics does the nurse need to explore?
You need forensic detail. You have to ask about the character. Is it sharp? Is it dull? Burning? Cramping? The duration, the pattern, is it intermittent or constant? And the frequency. You need to map the location and critically identify the distribution of any referred pain.
Like gallbladder pain.
Exactly. Pain from the gallbladder or duodenal ulcer often follows nerve pathways that radiate to the back or the right shoulder. You can see this in figure 38-3.
And what factors influence the pain?
This is a huge diagnostic clue. Does the pain get better with rest? Does it get worse with activity? Does eating aggravate it, which might suggest a gastric ulcer? Or does it alleviate it, which could point to a duodenal ulcer? Is it relieved by defecation? These details guide the whole differential diagnosis. You mentioned dyspepsia or indigestion is the most common symptom. How do patients usually describe this vague discomfort?
It covers a whole range: pain, fullness, bloating, a feeling of early satiety, getting full, too quickly belching, heartburn, or regurgitation.
And as the nurse, you should proactively ask about specific trigger foods. We know fatty foods tend to cause the most distress because, thanks to CCK, they stay in the stomach for longer. Salads, coarse vegetables, highly spiced foods can also be problematic for some people.
And let's just reiterate the difference between common, occasional gastroesophageal reflux, GER, and the more serious chronic presentation, GERD.
Right. GER is transient and it's pretty normal. GERD is defined by symptoms happening 2 or more times a week or causing complications. It affects a huge segment of the population, and it definitely increases with age because of those physiological changes we talked about, like decreased LES pressure.
Gas is often embarrassing for the patient to talk about, but we have to treat it clinically.
We do. Gas accumulation can manifest as belching, which is expulsion from the stomach, or flatulence, expulsion from the rectum. Patients often present with bloating or abdominal distension. And persistent excessive flatulence is a clinical finding that should trigger an investigation for underlying issues like carbohydrate malabsorption or even gallbladder disease.
Okay, nausea and vomiting. We need to distinguish the vague sensation from the forceful action.
Right. So nausea is that vague sensation of sickness, and it's often triggered by distension in the duodenum or the upper intestinal tract. Vomiting, or emesis, is the forceful, involuntary emptying. The nurse's assessment here has to be immediate and really detailed.
What are we specifically assessing about the vomitus?
Volume, color, and content. If you see hematemesis vomitus that looks like bright red blood or dark coffee grounds, that signals a high-level upper GI bleed.
And the coffee grounds appearance means the blood is old.
It means the blood has been in contact with HCl long enough to oxidize. This is a critical sign of issues like a gastric ulcer or maybe a Mallory-Weiss tear near the gastroesophageal junction.
And the reflex origins are complex. It's not just the stomach acting up.
Exactly. The vomiting center in the brainstem can be activated by 4 different pathways. 1 is visceral pain or distension. 2 is signals from the chemoreceptor trigger zone, or CTZ, which monitors the blood for toxins or metabolic abnormalities.
Like from medications.
Right, like high calcium or drug side effects. 3 is signals from the inner ear's vestibular center for motion sickness. And 4 is signals from the cerebral cortex, which leads to anticipatory emesis, related to anxiety or memory. Identifying the pathway is often the key to choosing the right antiemetic.
Moving to changes in bowel habits, starting with diarrhea.
Physiologically, diarrhea is an abnormal increase in frequency and liquidity, and it happens because the chyme is passing through the intestine too rapidly. This means there's just not enough time for water, nutrient, and electrolyte absorption. It's often associated with cramping and urgency.
In constipation.
That's the opposite. Decreased frequency, passage of hard, dry, and small stools, requiring a lot of straining. Chronic constipation can lead to anal discomfort, and because of the straining, conditions like hemorrhoids or fissures, which can then present as rectal bleeding.
I want to dedicate a moment to the nursing research insight detailed in chart 38-1. It's about functional constipation, or FC, and it's so relevant for patient education.
Yes, this study demonstrated the profound impact of structured nursing intervention. So FC is a persistent, chronic, non-pathological problem with elimination. The study compared routine care with a nurse-led self-management education intervention.
What did that intervention actually involve?
It was a really proactive, comprehensive approach. The nurses provided specialized education, they helped patients develop individualized self-management plans, and they encouraged consistent journaling of food and lifestyle choices.
And the results were decisive, really highlighting the nurse's role as educator.
Absolutely. The intervention group saw significant improvement in their constipation scores, and critically, they showed a higher adherence rate to healthy habits. This included proper use of fiber and laxatives, appropriate diet and fluid intake, and training in healthy defecation habits. The implication for you at the bedside is clear. Education and empowerment are the most effective long-term treatments for these functional bowel disorders.
Let's talk about stool characteristics. When we talk about blood, the color tells a story about the location, doesn't it?
It does. If the blood comes from the upper GI tract or has a long transit time, it oxidizes and becomes melena, which is terry black, sticky, and foul-smelling. If blood enters the lower GI tract or passes very rapidly, it will appear bright or dark red.
And streaking.
Streaking of bright red blood on the surface of the stool or on the toilet paper is usually benign. It suggests lower rectal or anal sources like fissures or hemorrhoids.
What other signs must we note?
Stools that are bulky, greasy, foamy, or have an extremely foul odor often indicate malabsorption. The fat content is just too high. If the stool is light gray or clay-colored, this is a critical sign that bile flow is impaired or obstructed, since the normal brown color comes from that conjugated bilirubin breakdown. We also have to note any mucus, pus, or small, rock-hard masses.
The text provides a really helpful reminder in Table 38-4 about non-pathologic causes of color changes, which can prevent a lot of unnecessary panic.
Yes, the nurse must confirm the patient's intake. Iron supplements, bismuth-like Pepto-Bismol, and black licorice all commonly turn the stool black. Barium from a study will turn it milky white. And, leafy green vegetables can turn it greenish-brown. Distinguishing these benign causes from internal bleeding is a key assessment skill.
Before we move to the hands-on assessment, what else is crucial in the history?
Comprehensive lifestyle details. You need specific questions about daily food intake, any food allergies or intolerances, and a detailed history of alcohol and tobacco use, the type, the amount, the duration. Alcohol and smoking are massive risk factors for many GI cancers and inflammation. You also need to note any significant unexplained weight gain or loss and verify the patient's dental hygiene, including specific care of their dentures or partial plates.
And Chart 38-2 emphasized denture care as a health promotion point.
It's vital patient teaching. Dentures have to be cleaned thoroughly twice a day. Patients should cut non-sticky foods into small pieces and chew slowly. And the most critical point, dentures must be removed and soaked nightly in water or a denture product, and never hot water, which can cause warping. And you have to stress the need for regular professional dental evaluations.
Now we move to the physical examination: the mouth, the abdomen, and the rectum. Let's start with patient preparation for the abdominal exam.
Comfort is key. The patient should be supine with their knees slightly flexed to make sure the abdominal muscles are relaxed. The bladder must be empty, the room should be warm, and the examiner should have warm hands and short fingernails.
We start at the entry point, the oral cavity.
First, you remove any dentures or partial plates. We inspect the lips for moisture and color. We examine the buccal mucosa, looking for the small red dot of the Stenson duct near the upper molars. We look at the gums for inflammation or bleeding. And critically, we note any unusual breath odor, which can signal things like diabetic ketoacidosis, liver failure, or uremia.
And the assessment of the tongue and pharynx is a built-in neurological check.
It is. We inspect the dorsum of the tongue for its texture and any coat. We ask the patient to protrude their tongue and move it laterally. This assesses the strength and symmetry, which tells us about the integrity of cranial nerve 2O, the hypoglossal nerve.
We also have to look for the high-risk sites for cancer.
Yes, you have to inspect the ventral surface of the tongue and the floor of the mouth very carefully. Look for any suspicious white or red plaques, nodules, or ulcers. Then, to visualize the pharynx, the patient says, "ah," while you depress the tongue. You watch for the symmetric rise of the uvula and soft palate, which assesses the integrity of cranial nerve X, the vagus nerve.
Okay, now for the abdominal assessment. This section contains the single most important procedural distinction in physical assessment.
Absolutely. The sequence is rigid and it is crucial. Inspection, auscultation, percussion, then palpation, IAPP.
And the mnemonic is simple, but the reason for it is critical.
It's so critical. You have to auscultate first because percussion and palpation, actually manipulating the abdominal contents, can stimulate bowel motility and artificially alter or increase bowel sounds. This can lead to a false finding.
We also need to map the location of our findings.
We can use the traditional 4 quadrants, RUQ, LUQ, RLQ, LLQ, or the more specific 9 regions, like epigastric or umbilical. Consistency in your documentation is just paramount.
What are we inspecting for?
We're looking for skin changes, scars, lesions, striae, any jaundice color. We assess the contour. Is it flat, rounded, staphoid symmetry, and any localized distension. In very thin patients, you might even see normal, slight peristaltic waves.
Now, auscultation. What are the characteristics of normal bowel sounds?
We use the diaphragm of the stethoscope for the soft clicks and gurgles. Normal frequency is about 5 to 30 sounds per minute, and we categorize them as normal, hyperactive, so increased frequency, or hypoactive, decreased frequency.
And the listening rule for confirming they're absent.
To declare bowel sounds truly absent, which is a sign of a very severe problem like a paralytic ileus, you must auscultate for a minimum of 5 minutes. That's at least 1 minute in each of the 4 quadrants.
And we switch to the bell of the stethoscope for vascular sounds.
The bell is used to listen for bruits, which indicate turbulent blood flow over the aortic, renal, iliac, and femoral arteries. We also listen for friction rubs, a sort of grating sound over the liver and spleen, which can indicate inflammation. And of course, that loud, prolonged gurgle everyone calls stomach growling is officially documented as borborygmus.
Next up, percussion.
Percussion helps us assess the size and density of organs, helps locate masses, and detects air or fluid. We expect to hear tympani, a drum-like sound over areas with air, typically the stomach and intestines. We expect dullness over solid organs like the liver or over a solid mass or fluid collection.
And finally, palpation.
Palpation starts light to identify tenderness or any involuntary muscular guarding, which suggests irritation. Then we move to deep palpation to identify masses or deep tenderness. And a clinical note from the text is important here. Many examiners today use light percussion to assess for peritoneal irritation instead of the traditional rebound tenderness test.
Because that can cause a lot of pain.
Severe, unnecessary pain.
The last segment of the physical exam is mandatory but often uncomfortable. Rectal inspection and palpation.
It is essential for completeness. Positioning the patient is key for comfort and visualization. Left lateral with the knees flexed is common. We first inspect the external area for lumps, rashes, fissures, fistulas, pilonidal abnormalities. We ask the patient to bear down, which helps reveal any hemorrhoids or prolapse.
And the internal exam technique.
The examiner uses a gloved, well-lubricated index finger. We assess the tone of the internal anal sphincter and check for any nodules or irregularities. Since this is uncomfortable, the nurse has to provide clear communication, encourage deep breathing, and make sure the procedure is brief. The sample you get should be assessed for color and occult blood immediately.
We've completed the physical assessment. Let's move into the diagnostics. Before listing specific tests, what are the overarching nursing interventions that apply to almost all GI diagnostics?
The general interventions are crucial, and they're often high stakes. The nursing role involves providing clear education, managing anxiety, alleviating discomfort, and reporting any comorbidities or baseline abnormal lab values. But the single most important, consistent task is maintaining adequate hydration.
Because of all the preps.
So many procedures require fasting or aggressive bowel preps, which can induce severe fluid and electrolyte imbalance, especially in older or high-risk adults.
Let's start with the basic serum laboratory studies.
Initial blood work usually includes a complete blood count, CBC, a complete metabolic panel, so that's checking electrolytes and liver function, PT-PTT for coagulation status, which is vital for invasive procedures, triglycerides, and those crucial pancreatic markers, amylase and lipase.
We also use specific tumor markers in GI health.
Yes, specifically CEA, carcinoembryonic antigen, and CA19-9. While they aren't perfect screening tools for an initial diagnosis, they are highly sensitive for monitoring treatment effectiveness and detecting recurrence in patients with colorectal and hepatocellular carcinomas.
Moving to stool tests. What are the nursing collection guidelines?
Stool can be collected randomly, but quantitative studies, like a fecal fat analysis, require a 24 to 72-hour collection period, and those samples must be kept refrigerated. The patient may also need specific dietary or medication restrictions beforehand.
Let's compare the traditional versus modern occult blood screening. The old standard is the guaiac-based fecal occult blood test, the GFOBT.
Right, the GFOBT uses a chemical reaction to detect blood. The restrictions are high stakes, and patients frequently miss them. They have to avoid red meats, aspirin, and NSAIDs for 72 hours because these can cause chemical irritation or minor bleeding, which leads to false positive results.
And on the other side?
Ingesting high doses of vitamin C can interfere with the chemical reaction, causing a false negative result. Also, you just don't perform this test if active hemorrhoidal bleeding is present.
The newer alternatives are much simpler for patients.
So much simpler. The fecal immunochemical test, or FIT, is simpler because it reacts specifically only to human hemoglobin, so it requires far fewer dietary restrictions. It's typically done annually. The most advanced is the FIT fecal DNA test, which detects abnormal DNA sections shed by polyps or cancer cells. It has no dietary restrictions and is approved for use every 3 years.
Finally, breath tests. These are excellent non-invasive diagnostic tools.
The hydrogen breath test is used to evaluate carbohydrate malabsorption. If certain sugars aren't absorbed in the small intestine, bacteria in the colon ferment them, producing hydrogen gas, which is absorbed into the bloodstream and then expelled in the breath. This helps diagnose conditions like bacterial overgrowth or lactose intolerance.
And the high-stakes test for H. pylori.
That's the urea breath test. Think of it this way. The H. pylori bacteria have a unique enzyme, urease, that lets them quickly metabolize urea. We give the patient a small meal of carbon-labeled urea. If the bacteria are present, they consume the urea and then exhale the labeled carbon as carbon dioxide, which we measure. No other common organism does this.
The nursing intervention regarding pre-test restrictions for the urea breath test is critically important for accuracy.
This is a major test point. Failing to adhere guarantees a false negative result, which leads to delayed treatment. The patient has to avoid antibiotics and bismuth subsalicylate for 1 month prior. They have to avoid proton pump inhibitors, PPIs, for 2 weeks, and H2 receptor blockers like cimetidine or famotidine for 24 hours. These meds suppress the bacterial action, skewing the result.
Moving to imaging, starting with abdominal ultrasonography, US.
US is non-invasive and uses sound waves. It's a first-line diagnostic for things like gallstones, an enlarged gallbladder or pancreas, ectopic pregnancy, and appendicitis. Its major advantages are quick results and, of course, no ionizing radiation.
What are its limitations?
Its utility is severely limited by the presence of gas, fluid, or bone in the abdomen, which scatters the sound waves. And patient body habitus can also be a limiting factor.
So how does endoscopic ultrasonography, EUS, overcome these limitations?
EUS places a high-frequency transducer directly on the tip of a fiber optic scope, allowing for internal visualization. Because it bypasses all that intervening gas and adipose tissue, it provides much higher resolution images. It's used for submucosal lesions, evaluating the depth of cancer staging, chronic pancreatitis, and Barrett esophagus.
What are the nursing interventions for a standard US?
Patients need to fast for 8 to 12 hours to decrease gas. If it's a gallbladder study, they need a fat-free meal the night before. And crucially, U.S. procedures must be scheduled before any barium studies because barium completely blocks the transmission of sound waves. And if sedation was used, you're monitoring their LOC and ambulation status.
Let's briefly address genetic testing, which is mentioned in Chart 38-3.
Genetic testing can identify predispositions for specific disorders, things like hereditary gastric cancer, Lynch syndrome for colorectal cancer, or certain malabsorption conditions. The nursing role here is to meticulously assess the family history, looking for early onset cancers, IBD, congenital anomalies, to help guide targeted screening recommendations for that patient.
Now, on to contrast studies. First, the upper gastrointestinal tract study, or barium swallow.
This involves the patient drinking a radiopaque liquid, barium, while x-rays are taken. It's used to detect disorders like ulcers, varices, tumors, or malabsorption.
The variations are important for specificity.
Right. The double contrast method is often used. It combines thick barium with tablets that release carbon dioxide gas. The air provides contrast, showing fine mucosal detail, which is essential for identifying early, superficial neoplasms. Then there's the highly invasive but very detailed enteroclysis, which involves continuously infusing thin barium and metal cellulose through a duodenal tube to visualize the small intestine. That procedure can last up to 6 hours.
What are the mandatory nursing interventions for the UGI study?
Patients need a low residue or clear liquid diet and have to be NPO after midnight. And here's a critical nursing alert. The patient must be instructed not to smoke or chew gum during that NPO period. Both activities increase gastric secretions and salivation, which interferes with the coating action of the barium.
And post-procedure.
The primary nursing priority is encouraging high fluid intake to ensure rapid elimination of the barium, preventing it from hardening and causing a potential impaction.
Next, the lower gastrointestinal tract study, or barium enema.
This involves the rectal installation of barium to delineate the large intestine, detecting polyps, tumors, and anatomical abnormalities. Again, air is often instilled, the double contrast method, for better mucosal visualization. If you suspect a perforation, a water-soluble iodinated contrast like gastrographin is used instead, which of course requires an iodine allergy screen.
The prep here is demanding.
It is intensive. It requires a low-residue diet for 1 to 2 days, clear liquids, laxatives the evening before, and cleansing enemas. And there are crucial contraindications. The procedure can't be performed if the patient has active acute inflammation, a suspected perforation, or an obstruction, because instilling the contrast could make the condition much worse.
And post-procedure, again, fluids are key.
Fluids remain high priority, and nurses have to monitor for evacuation. The high osmolarity of barium can actually cause a temporary increase in fluid output.
Moving to cross-sectional imaging. Computed tomography. CT.
CT is invaluable for inflammatory conditions, appendicitis, diverticulitis, ulcerative colitis, as well as diseases of the liver, spleen, and pancreas. It frequently uses oral or IV contrast agents for enhanced visualization.
And if IV contrast is used, the safety alert regarding contrast-induced nephropathy, or CIN, is paramount.
This is a high-stakes safety check. As a nurse, you have to screen for allergies to contrast, iodine, or shellfish. Most importantly, you must verify the current serum creatinine level and assess pregnancy status. The contrast agent poses a risk for CIN. Hydration management before and after the procedure is the most effective way to prevent this kidney damage.
Now, magnetic resonance imaging, MRI.
MRI uses magnetic fields and radio waves, and it's excellent for evaluating soft tissues, vessels, fistulas, and abscesses. However, its quality is susceptible to movement artifacts from things like peristalsis or breathing.
And the MRI safety alert is an absolute life or death priority.
It is the most stringent safety check in all of imaging. MRI is an absolute contraindication for any patient with a device containing metal that can be displaced or malfunction in that high magnetic field. We're talking pacemakers, specific aneurysm clips, cochlear implants.
And what about patches?
Nurses have to ensure the removal of all jewelry and items like foil-backed skin patches, like nicotine or pain patches, because the foil can heat up and cause severe burns. You have to consult with the provider before removing any medication patch.
What are the necessary patient teaching points for the MRI experience itself?
NPO status is usually required for 6 to 8 hours. The procedure takes 60 to 90 minutes and involves loud knocking sounds, so you have to proactively address claustrophobia, offering music, blindfolds, or discussing the option of an open MRI.
Lastly, PT scans and scintigraphy.
PT scans detect radiation from intravenously injected radioactive substances, creating hotspots that identify areas of high metabolic activity. They're often used to stage cancer. Scintigraphy, or radionuclide testing, uses specific isotopes to track tagged materials.
What's a key clinical use for that?
Tagging red blood cells or leukocytes to pinpoint the source of internal bleeding, inflammation, or abscesses when all other imaging tests have been negative.
We've saved the most invasive and crucial studies for last, starting with GI motility studies.
These procedures measure how fast material actually moves. The gastric emptying study involves tagging a solid meal, usually scrambled eggs, and a liquid meal with a radionuclide marker. A CT scanner then measures the rate of passage from the stomach. This is vital for diagnosing motor disorders like gastroparesis, which is delayed emptying, or dumping syndrome, which is rapid emptying.
And for measuring colonic speed.
The colonic transit study requires the patient to swallow a capsule containing 20 radiopaque markers. X-rays are taken every 24 hours until all the markers have been passed, a process that can take anywhere from 4 to 10 days. It gives you a clear measure of the speed of colonic motility.
Now, the cornerstone of direct visualization, upper GI endoscopy, EGD.
EGD allows for the direct visualization of the esophageal, gastric, and duodenal mucosa using a flexible, lighted fiber optic scope. And it is both diagnostic for ulcers, tumors, inflammation, and therapeutic.
What are the therapeutic applications?
Endoscopy allows for immediate intervention. You can dilate strictures, remove stones, and treat upper GI bleeding using sclerosing solutions, clips, or laser therapy.
What are the essential, non-negotiable nursing interventions for an EGD?
The patient must be NPO for 8 hours. Before insertion, a local anesthetic spray is used and moderate sedation is administered, often midazolam, sometimes along with atropine or glucagon to reduce secretions and motility. And the patient is always positioned in the left lateral position.
Why is that position so important?
To facilitate the clearance of pulmonary secretions and prevent aspiration.
And post-procedure, what is the single highest priority safety check?
Continuous monitoring of LOC, vital signs, and O2 saturation. But the highest priority before you offer anything by mouth is to assess for the return of the gag reflex. The local anesthetic suppresses this reflex, making the patient highly vulnerable to aspiration if they eat or drink too soon.
And what are the signs of perforation we have to teach the patient's accompanying person?
Since the patient will likely have amnesia from the sedation, verbal and written instructions detailing the warning signs have to go to the person taking them home. These signs include pain, bleeding, difficulty swallowing, and a rapidly elevated temperature.
Briefly touch upon ERCP.
Endoscopic retrograde cholangiopancreatography, or ERCP, combines endoscopy with X-rays to visualize the bile ducts, pancreatic ducts, and gallbladder, all accessed via the ampulla of Vater. The trend now is less diagnostic and more therapeutic, focusing on things like stone retrieval and stenting blockages.
Finally, the gold standard for large intestine screening, fiber optic colonoscopy.
This provides direct visualization of the entire large intestine, from the anus all the way to the ascending colon. Its primary application is cancer screening, surveillance, and the immediate removal of polyps, or polypectomy.
And the success of the colonoscopy relies entirely on the quality of the bowel preparation.
Absolutely. The preferred superior cleansing method today is the PEG electrolyte lavage solution using a split dose regimen. So half the solution the night before and the second half about 3 to 5 hours before the test. This results in much better cleansing and higher detection rates.
What specialized monitoring is required during this intense prep period?
Nurses have to monitor older adults very closely for fluid and electrolyte imbalances due to the sheer volume of output. Additionally, the cold prep solution can induce hypothermia, so keeping them warm is important. And diabetics require careful adjustment of their insulin and oral hypoglycemics because of the fasting.
And the safety alert regarding implanted devices during a colonoscopy.
If the endoscopist plans on doing any electrosurgical procedures, like a polypectomy, patients with implanted pacemakers or defibrillators require a mandatory cardiology consult beforehand for device management. The electrocautery poses a risk of malfunction.
And post-procedure, what are the red flags?
Continuous monitoring for signs of perforation, significant rectal bleeding, more than just spotting severe abdominal pain, distension, and fever.
Let's discuss the other motility and pressure studies. Manometry.
Manometry evaluates motility disorders by measuring the intraluminal pressure and muscular coordination. Esophageal manometry can detect disorders like achalasia, which is absent peristalsis, or diffuse spasm. Your nursing instruction requires holding motility-affecting medications like calcium channel blockers for 24 to 48 hours, and NPO status.
And the measurement of gastric secretions.
That's the gastric analysis. It measures HCl secretion and is useful for diagnosing conditions like Zollinger-Ellison syndrome, which is excess HCl, or atrophic gastritis.
If the provider orders a stimulation test during that gastric analysis, what's the risk?
If histamine or penagastrin is injected to stimulate acid production, the nurse has to anticipate and monitor for a major side effect, hypotension. Blood pressure and pulse must be monitored frequently, and you should inform the patient they may experience a transient flushed feeling.
What about long-term pH monitoring?
The Bravo pH monitoring system is a really high-tech solution. A tiny capsule is temporarily attached to the esophageal wall during an EGD. It transmits pH data for up to 96 hours while the patient resumes their normal diet and activity. It provides a far more accurate picture of reflex frequency than the older methods.
Our final advanced procedure, laparoscopy or peritonioscopy.
This is a minimally invasive diagnostic and surgical tool that requires general anesthesia. To create a working space, the abdomen is inflated with carbon dioxide, a process called pneumoperitoneum. This separates the organs, allowing for direct visualization, biopsy, and often immediate surgical excision, like a gallbladder removal.
That CO2 inflation is necessary, but it often causes an expected side effect post-op, right?
Yes. The CO2 that gets retained under the diaphragm often irritates the phrenic nerve, causing shoulder pain. The nurse should anticipate this and teach the patient that this referred shoulder pain is a common, though uncomfortable, side effect of the pneumoperitoneum.
We have completed the journey from ptyalin and salivary amylase to advanced procedures requiring pneumoperitoneum. This chapter demands a real mastery of detail. What are the essential nursing takeaways that consolidate all this extensive knowledge?
Your success really depends on integrating that anatomical knowledge with a detailed symptomatic history taking. You have to internalize the high-stake patient prep requirements, knowing the specific NPO status times, the strict medication hold times for the H. pylori test, and the absolute contraindications for advanced imaging like MRI.
And constant vigilance for safety and fluid balance.
Exactly. The nurse's role is defined by pre-procedure education, preparing the system correctly, and aggressively managing that high risk for fluid and electrolyte changes that's inherent in rigorous bowel preps. You absolutely have to know the red flags, the signs of perforation after any invasive procedure like an endoscopy or colonoscopy.
We've established that the gut microbiome is vital for immune function, and that genetic predispositions influence risk for chronic inflammatory disease.
That's the direction the field is moving, for sure.
So here's the final provocative thought for you, the learner. Given the rapid advancements in genomic medicine and our increased understanding of the microbiome's role in health, how might future nursing assessments integrate formalized genetic screening and targeted microbiome analysis into standard, routine clinical practice? How will that change the way we assess chronic disease risk? The field of GI health is dynamic, so stay curious and keep learning.
Thank you for joining us for this comprehensive deep dive into GI assessment.
We hope this synthesis helps you master your next exam and your next critical clinical shift. We'll see you next time on The Deep Dive.